Hi, Matthew Holt here with the Healthcare Blog on the TCB Spotlight. I'm here with Dr. Kaelee Brockway. Kaelee is a doctor of physical therapy and of education. Am I right there?
That's right.
Far too many degrees. And she is from the St. Augustine University of St. Augustine Health Sciences. Tell me a little bit about the university, Kaelee, and then tell me a little bit about what you do.
Yeah, absolutely. So I work at the campus location in Dallas, Texas, but we do have 8 physical therapy programs across 5 different geographical locations. We are the biggest university that teaches physical therapy across the United States. We also have occupational therapy, speech language pathology, and advanced practice nursing in a couple different areas. And a post-professional education doctorate program. So we kind of cover like a huge gamut of the allied health sciences, and then we create educators.
Fantastic, and I suspect that every single one of your students is snapped up immediately. They walk out the door, probably before they walk out the door, given the shortages in I think everything that you just mentioned. But
Yeah.
that's fantastic. And give me a bit about your background. Were you always an academic? Were you a practicing physical therapist? How did you get to where you are now?
Yeah. So I was a practicing physical therapist for 7 years, primarily in home health. I spent a lot of my practice treating people who had advanced heart and lung disease. So I was a heart and lung transplant program educator for several years and fell in love with the cardiovascular and pulmonary system. So that's primarily what I spend my time teaching now that I'm an academic. I'm also a board certified geriatric specialist. So if you are over the age of 50, I'm sorry to tell you, but you fall into my practice. So I'm happy to see you for any of your needs, past, present, or future.
Well, I will whine to you about my knee hurting for.
Yeah,
I've done a number of them. Not the topic for the day, but I've done a number of the online physical therapy. I've done the home visit. I've been a good patient, or not a good patient, depending on.
very good.
So the reason we're talking today is because AI is changing the world everywhere and everything, but probably it's taking a little longer to get into sort of the training of health professionals. And you've built some interesting AI tools for the way you're training with your students. So can you tell me a bit about how you did that, how you got to build this thing, and I think you're pretty early in terms of people who've been doing that. And then we're going to take, and after you've done that, we'll take a little look at what you built and see what the student experience is.
That sounds great. Yeah. So, working in academia since 2020, and this AI thing came up kind of in my world about 18 months to 2 years ago. And I saw this and thought, oh my goodness, my students are going to be using this. So I don't want to be behind. I want to understand what they're doing and how they're doing it. So I need to be up with the tech and the times. So I explored some options and ended up getting a Google Cloud certification in AI and large language models so that I would have some type of understanding of what on earth my students are doing. Um, to my surprise, my students were not using AI nearly as much as I thought they were.
It's the high school kids who are using it for their essays.
Yeah,
They're too old.
yeah, absolutely. But they're also using it in ways that I don't want them to use it. They're using it in ways that are going to get them in trouble or ways that it's not going to be productive. So I also lead the teaching and learning course in our curriculum, and I take it upon that course to take some moments to teach them about AI, how to use it proactively and responsibly, the difference between open loop and closed loop systems, what hallucinations are, how to identify all the errors and problems, and when to and when not to use it.
All right. No, I mean, and that's stuff that I think we're all learning as we go.
Yeah.
And people are obviously getting experience to prompting. It's kind of interesting the way that if you look at uh, a lot of people have used ChatGPT, right?
Yeah.
And there's lots, OpenAI, of course, is doing super well, and you can, it's now the main part of the Google search. The rest of the Google searches are actually going down, but people are
So
still
that's
it's still
Gemini.
delivering different and wrong answers all the time. And you have to be smart to be able to figure out where it's hallucinating and how to use it. But certainly, incredibly powerful tool.
Yeah.
So you've picked up on a particular area
Yes.
for the use of AI, and you built some bots and some personas for that. So, what was that area? Why did you do it? And let's see what you've done.
Yeah. So the students that are coming into my programs now are they've already gotten an undergraduate degree and they're coming in for their postgraduate education. That's the level of education for physical therapy students in the United States is an entry level doctorate degree. So that's what we provide. And these students, specifically in the last 2 to 3 years, have been the COVID generation. They were the generation of students who did their undergrad online for a large majority of the time. They are students who lived on social media because that was the only social interaction that they had during lockdown. So these students are not really necessarily prepared or geared to jump into a face-to-face difficult situation with someone that they don't know, and they need a little prep ahead of time to plan out how best to address those kinds of situations. So I've built some AI chatbots that focus on what we call the soft skills, managing difficult conversations, managing empathy in conversation, advocacy for a patient or for yourself, and really just kind of turning around how we're immersing our students in simulated activities, backing up the train a little bit so that we're preparing them well to go into those real scenarios by practicing ahead of time.
No, that's excellent. And it reminds me of we got a dog the year before COVID who got socialized well and met lots of other dogs and lots of other people. And then we had a dog during COVID who still has problems with anybody who's not her immediate family.
Yep. Yep.
It's the same
Same
issue.
thing.
So yeah, fantastic. So why don't you show us the actual experience of you've got a couple of personas that you're going to show us. So just the experience of what a persona. So a student would, on their own time, I assume, be told, okay, go do this part of the course, and the course is you're going to talk to this chatbot and you're going to practice, and they're presumably well. We'll talk. Why don't you show me what it is, and we'll talk about how they're scored and how they're improving while they do it.
Okay, great. So, we send our students out into clinical education, and we can, for the most part, we have an idea of the experiences that they're getting when they're out in the clinic. But standardizing soft skill education is a lot harder, and the experiences have to present themselves, and that doesn't always happen. So, we've got some experiences here that are built into one of the courses that they take that happens before they go out into the clinic. So, it's very intentionally timed as well. So this patient is Mr. George, and in our learning management system, what I will hitherto refer to as the LMS, we have the opportunity to do one of two different types of AI chatbots. So we can do either a role play chatbot or a Socratic questioning chatbot, more like a quiz game. But these are role play chatbots. So I've built the scenarios for the role play chatbot. I've built their AI personas. And these AI personas and scenarios are fully based on experiences that I have had in my clinical practice, experiences with managing very difficult situations or uncomfortable conversations. And the goals that the student has to achieve are put out in front of them. There are student facing parts of this as well. So we put the goals of that the student has to achieve up front. And then the AI persona also has goals that it has to achieve in the conversation. What's really great about this particular build of a language model and chatbot is that if the student is not doing well at achieving its goal, the way I've programmed it, it will actually start helping the student achieve its goal. So it'll start adapting to the communication the student is providing. We are limited to a text-based chat version of this at the moment, but we are working on transferring over to voice. So that's going to be a future direction. But let's take a look at Mr. George and look at how talking with him goes. Mr. George is in pain. He just had a right hip replacement. He's very frustrated. His pain is not being managed. And if the students are going to work with him on his physical therapy session today, they need to take this opportunity to practice their empathetic pain science-based communication. And their goal is to get Mr. George to consent to participating in physical therapy today. So we're going to take a run at this chat. So you can see up front that the scenario is provided. The nurses have tried to get him out of bed. He's not having it. And he's just like really not letting anybody deal with him today. And now it's my turn to go in and be his therapist.
Pretty amazing that they didn't just send him home straight away from a hip replacement these days. He got a night in the hospital before to get grumpy.
I So this actual person that Mr. George is based on, he had quite a bit of medical complexity with some diabetic issues. So
Probably,
he
probably,
was,
probably a good idea to let him spend one night in the hospital.
yeah, he got 3 nights. He was lucky. All right, so I have some responses that I've kind of prepared in advance just to expedite this process. So I'm going to be copying and pasting so you don't have to sit there and watch me type and spell half the words wrong and have to autocorrect and all that stuff. So I'm going to say, Mr. George, my name's Kaelee. I'm from physical therapy. I'll be working with you today. How are you feeling? And Mr. George is going to come back and tell me he's not feeling very well. He has a lot to say today. And he says, well, to be honest, I'm in quite a bit of pain. I don't see how getting out of bed is going to help anything. It just hurts too much. I appreciate you being here, but I am not up for this today. Now, at this point, as the instructor of the class, this can either go one of two ways. It can go very well, where the student does exactly what they should do, and they get very empathetic and they employ their pain science education and they have that style of conversation. But I'm going to show you what happens when it doesn't.
Okay.
All right. So
I won't ask how many of your students it goes well versus badly, but I'm sure at the end of the class it's going well.
They usually do okay. Yeah. All right. So I'm going to say, well, the doctor says we have to get you up and get moving. So that's the plan for today. I'm not listening. I'm passing the buck. I'm blaming someone else, right? This is not what we should be doing. Kaelee, I know the doctor thinks it's best, but I don't think anyone understands just how much pain I'm hurting right now. The thought of moving makes it feel worse. Can you blame me for not wanting to go through even more pain? And I'm going to continue to not be empathetic and say, I'm just here to help you. And if you don't get out of bed, we can't send you home. I don't think you want to be in a nursing home, do you? You'll never say this in real life. And he says, that really hits a nerve. I don't want to end up in a nursing home, but right now, all I can think about is the unbearable pain I'm feeling. I need someone to understand what I'm going through instead of someone pushing me so hard. Can't we make this easier somehow? So you can hear at this point, there's a little bit in there where he knows, the chatbot knows the student is not doing what they should be doing, and he's trying to cue the student very subtly. So I'm going to continue to do poorly and say, I already know pretty much everything I need to know about you from your chart, and I know you want to go home after this, so that's what I'm here to help you do. And he's like, I know you're trying, but you're also not hearing me. This is not going well. This pain is overwhelming. Can we talk about how we might ease into this without making the pain worse? The chatbot again is now starting to cue me. Like, you're not doing well. Try again. And continuing down the negative road, I'm going to say, when was the last time you got some pain medication? I'm going to pass the buck. Say, I'm not dealing with this. We're going to get someone else to help you. And he's like, I'm willing to listen if we can figure something out. It just doesn't make me feel like I want to be thrown into more pain. Can't we talk about it? And as a very, very bad PT, I might say, well, I'll come back later today after you've had more pain medication, which I would never do. But that's painful. It's painful for me to even copy paste. But he says, I appreciate the thought of you giving me more time, but it feels like now we're just delaying and not addressing my problems. I need to know how we can approach this without making everything unbearable. Can we talk through some steps, some options? Even if it's just some small talk, I want to work with you, but I need to feel like you're working with me too. So the chatbot's going to go on to continue to try to drag out of the student something positive in this interaction, but it's obviously not going well. So this is an example of a very negative interaction from the student or the PT perspective, and the AI chatbot is feeling that, and it's starting to try to pull the student back on track. So that's Mr. George.
So is it so you can imagine this, right? And
yeah.
There's always been role plays. If you remember the Seinfeld episode where Kramer is acting as a pick of disease, like doing role play at medical school, there's always been this stuff, but now we've got to be able to do this. So you've built a chatbot who has a persona, but also is also in there is trying to be instructional as well. how are you scoring this behind the scenes? How are you if you're thinking about reviewing the progress of a student,
Yeah.
how are you as an instructor, seeing what's going on here?
Yeah, so once the student completes their conversation in the student version of this, because this is the instructor version where I can build and edit. Once the student is done with their conversation and they feel like they've achieved their goal, so if this were to go well, he would say, "Yeah, let's do it. Let's get up." I'll demo the good end for you too, so you can see how it goes well.
Okay.
But once they've achieved their goal, they can hit save and submit, and it'll submit it, and I'll be able to see this on the back end in the gradebook, and I can go through their conversation line by line and actually add comments to say, you did really well here. This is a really empathetic statement. You validated his concerns with his pain. Great job achieving your goal. Or I can say, you might want to rethink how you phrase this statement because this makes it sound like you're not listening and you're just trying to push through your schedule for the day.
Does the tool score it itself, or is it just providing at the moment just providing you with text?
Yeah, it's just providing me with the conversation. And the way that we have these structured right now is the conversation itself is not scored. It's an opportunity to get formative feedback on how to improve and do better. And that has a big component of like psychological safety, which is a term we use in simulation a lot. If a student doesn't feel like they have psychological safety in a scenario, they will not be themselves in a scenario. And then we have no authenticity to grade them on.
I see.
So there's intentionally no grade attached to the conversation so that they can achieve their goals in the way they authentically would. What we do grade them on is a reflection that they have to do after the fact. What they learned about this communication style, what they learned about managing chronic pain, and that's what they get graded on.
All right, fantastic. Okay, I think you have another one to show me for a different scenario. Is that right?
I do, yes. So we have a scenario here. Are you still seeing my screen?
Yeah, we're seeing Bart head EMT.
Awesome, great. So this is also a scenario from my clinical practice. Nothing against the EMTs out there. This was one guy. Okay, doesn't apply to everybody. But I had been seeing a patient for some time. He had a very complicated neck surgery. He was supposed to be wearing a collar and wasn't wearing a collar. He had fallen and hit his head prior to me getting to this like fourth or fifth visit. And by the time I got there, he was a mess. He couldn't remember his name, his brother's phone number, where he was, nothing. So I had called 911 because he clearly needed some help. And the EMT who came to this house, which was way out in the middle of nowhere, very limited healthcare resources. The EMT who came told me that I shouldn't have called because he's just overdosing on his pain medications and he doesn't need to go to the hospital. Now, being the geriatric specialist that I am, in the 90 minutes it took that ambulance to get out into the middle of nowhere, I had done pill counts on 3 different pain medications. I had verified his prescriptions. I had checked his refill dates. I already knew that wasn't the case. So it became, I know, it became my job at that point to advocate for my patient to get the care that they needed. And to do that, I had to step into a very strong autonomy role. And that is what this scenario is asking the student to do.
Okay.
Okay. So you can see here, you've identified that your patient is experiencing some complications after surgery. The first responders arrive and they're hesitant to take him to the hospital because they think he's just taken too many pain meds. You must get your patient to the hospital. That is your goal. Okay. Bart, the EMT, though, he's very dismissive. He makes assumptions. He feels he knows the people who live out here and he feels that he knows what's going on in this scenario. So we're going to have a little chat with Bart. And the chat that I'm going to use for Bart is a chat that one of my students actually did. And this student is a military student. So you can imagine autonomy was not a struggle for this one. Right. And they did very well. All right. So they're going to open with, I'm the patient's physical therapist. This patient needs immediate medical attention. He had a recent cervical spine fusion, sustained a fall today, and is acting strangely due to a potential brain injury. His red flags, she's getting very medical, his red flags of memory loss, and he can't tell me his name or his family's name. And Bart comes back with, look, I know you're worried, and clearly you've got some knowledge, but people from this area over medicate all the time. It's probably just pain meds playing games with his brain. I see it all the time. A little rest and he'll snap out of it. Are you sure this memory thing isn't related to that? Because sending him to the hospital might not be needed. And like, that is very close to what I experienced in that real scenario without me even having to script it out. All I did was build who Bart was, and Bart is already responding to me in that way. So then the student said, with his recent surgery, he has hardware in his neck. He needs imaging and a neuroassessment to rule out some spine injuries. This is not a medication side effect because his symptoms are not consistent with that of opioid abuse. And I strongly recommend you transport him immediately. All right, I hear you. I hear you. You're adamant about his neuroassessment and imaging stuff, but I've got to say, I've seen folks this way more times than I can count. How do you know that for sure? Look, if you're absolutely positive about this and you're telling me we really need to roll, then I'll get him to the hospital, but you've got to be straight with me. Is this really necessary? And this is where this student puts on their doctorate degree and uses it. As my patient, I am responsible for his safety. And as his PT, I'm well versed in his signs and symptoms of drug abuse. Seeing that I'm a strong advocate against it, do not undermine my intelligence and expertise. If need be, I can assist you with getting him stabilized for transport. Thank you. I mean, this student just put their foot down. It was amazing. And so Bart eventually is like, all right, let's do it. Let's take him. I'm with you. I'll back off. But like, he still feels like, you know, he knows what's going on. His bias plays through, but eventually he gives in.
Oh, great. And I suspect, you know, this kind of interdisciplinary conversation happens quite a lot. I was thinking, you know,
unfortunately, yes.
Yeah. That's great. So that's wonderful. So you're currently so let's talk a little bit about a couple of things. I think we can you're not going to show me anymore. That's great.
Got you.
Just going. So you I assume that you built this by going to one of the commercial LLMs and saying, well, tell me how you did this and building these personas and prompting them, or was it something that you did? Is it how did you get from it would be a good idea to have this to actually building it?
Yeah. So I had gone to a conference and some other PTs were presenting on how they use an AI chatbot for a very specific patient care scenario.
Yeah.
And I was like, oh, that has such bigger use.
Yeah.
I need to expand that, right? And they were also using an external app, which it was open loop. And it wasn't like FERPA compliant or anything like that. And I was like, well, if we're going to do this, we need to do it right. We need to put some, you know, guardrails on this so it's secure. And if we're going to grade it, then we really need it to be secure because now this becomes protected information. So we worked with the LMS that we already contract with. And it turns out all it took was asking, and they just had to flip a few switches. Like they were ready with this and they were just waiting for someone to ask for it. And we asked and they were able to bring it to us within a very short amount of time. So we started building with the prompting. I started with just, you know, writing out a patient case scenario. That's not super effective when building an AI chatbot. It needs to have goals. It needs way more context than that can provide. Yep. So in building all of this, I came up with a prompt design that works really well for this too. And that's 3 components of the AI persona. You have to tell it what you want, why you want it, and who you want it for. So it has to know that this is for first-year PT students who are learning complex case management, because then it'll tone itself down. It won't fight as hard. Yeah. But that also means you can reprompt it just a little and get something tougher for higher level students. Yeah. Which is really nice. And then I just programmed in the scenarios from that point. And we did have to do a little bit of tuning with the outputs to make sure that they were consistent with what we were looking for as far as a PT scope of practice. But after I think we only did 2 or 3 rounds of tuning and we were exactly where we needed to be. So it worked really, really well.
So and when you say that your LMS provider, your LLM provider, is that one that's like one of the ones that's taken a version of Claude or OpenAI or whatever, and as ChatGPT, and provided it for you as an enterprise in the university, or
So they have their own.
okay,
They have their own closed loop system, which was really important for us because the representation of BART as a member of the EMT profession is not a good representation. we,
right.
we don't want that getting out into the world as like this is what EMTs do, because that's not what they're going for, I'm sure, right? So it was really important for us that it was closed loop. And so they were able to provide us our proprietary, just us. We're the only ones that it influences, and it stays very internal, which was really
Okay.
nice. Also safer for the students too.
Right. So push this out a few months, year,
Ugh,
whatever.
days.
What I mean, how long have you been using this with your students?
Yeah, we built the chatbots in this past fall,
Okay.
and they went into the courses live in the spring. And we since then have built 6 more that are really specific to interprofessional education.
Mhm.
Looking at like something happened in my PT session, I need to hand that off in an SBAR framework to a speech language pathologist who's coming in next. So we have those already built and ready to go into next term's courses. So this is going to kind of be a standard experience for us for our new curriculum.
Okay. So pushing it forward a little bit, in a year or two, what do you think the typical experience, how do you think this is going to change how we are training these trainees
Yeah.
that are going to be
Yeah.
medical professionals?
My big hope is that from a procedural standpoint, we go to voice, right? Because you
Yeah.
need to have the conversation live. That's the whole
And the just the vocal AI stuff is improving so quickly that shouldn't be too much of a problem. But go on.
I mean, at this point, you can hardly tell the difference,
Yeah.
right? Yeah. So as far as like how it's put into medical training, right now we're just using this as preparatory material. But as we move forward, I mean, it would not be beyond reason to have a telehealth AI virtual person who can talk to me and simulate a full scenario of telehealth patient care management by the end of this year.
Yeah, that makes a lot of sense. I saw my very first experiences down in NVIDIA a couple of years ago, and
Mm.
I made completely the wrong conclusion. I said, this is amazing. It's going to change the way we do interactions. I thought it was going to change therapy, particularly between patients and doctors.
Mm-hmm.
I think it still will. That was the wrong conclusion. The right conclusion was go out and buy more NVIDIA stock, which I didn't do. But that was a separate one. And then what are your goals for this tool? I mean, obviously, without putting you on the spot, there's a lot of medical education going on out there, and it hasn't changed that much in many decades in some cases, right?
No, it
We
hasn't.
know there is the simulation. If you just watch, how if you just, I mean, I happen to have watched Top Gun relatively recently, and then I saw the F1 movie, and if you look at people who are in real world situations, that the amount of simulation that those different types of trainees in pilots and drivers and whatever are using is tremendous, right? The amount of simulation done compared to the actual race or flight is
Yes.
is a big. I don't know what the parallel is, but it's a lot, right?
Mm.
5 or 10 to 1 or whatever. And they're using this in their testing scenarios, and we know that AI itself is supporting people in testing scenarios with simulation. So, what's your sense about how this is going to go forward, both as how medical professionals are going to use it, and then what do you think you're doing with it?
Yeah. So you touched on a few things there, and I think this is a really critical point that you brought up with simulation. Simulation hours in pilot training are massive, and we don't have nearly the same amount of hours in healthcare training, and yet we're going out and treating thousands of patients every single day, right? So there's a huge mismatch there. Our university, we are very heavy users of simulation. Every single course I teach is simulation based. We are always trying to get our students as much experiential learning as we possibly can. And simulation is a big component of that. Now, that's just speaking for physical therapy education. I know nursing does even more in our nursing, advanced practice nursing programs. They are constantly doing simulation. That's basically all they do. But as far as medical schools, it's not enough. It's just not enough. And that is a resource problem, it's an access problem, and it's a faculty time problem. There's a lot of components that go into that. Sim planning is a heavy lift, especially if you're going to make it a quality good scenario. I'm also a certified simulation healthcare educator. So I build a lot of this stuff together. And all I see, hopefully, as we move forward, is that AI has the potential to offload that process a bit and make it more accessible. But I want to be very clear that the human in the loop still matters more than anything else, because it's still the professor who has to make sure that the scenario is relevant, accurate, predictable enough that it's gradable, or at least formatively able to give feedback on it. And only the human expert can do that, because the computer AI has not practiced clinically. I mean, good for it. It can pass the board exam. Great. That's a multiple choice test. That's not patient care. And diagnosis is easy. I saw this quote the other day on LinkedIn: diagnosis is easy, disposition is war. And AI doesn't do that part.
Right. On the other hand, you've got on your behind your left shoulder, you've got the old format of how we used to transfer knowledge in the world, but in healthcare, in textbooks, right? And people would teach
and journals.
Journals. But you would use these things to teach. What's your sense about the use, the growth and the use of this type of AI and other more teaching tools?
Yeah.
As a sort of share of the activity, yes, even with guidance from professors and educators, as a share of how health professions are going to be taught.
Yeah, so with AI, it's really unique in that we are co-learning AI with our students, right? Like, right. It came out when we were all here. We are learning how to use it, why to use it, and when to use it together. So I think that's very hard to predict. I know students are copying textbooks into AI and saying, give me the SparkNotes summary of this. And I'm old, so I said SparkNotes, right? Like, they don't even know what that is anymore. They just put it into ChatGPT and say, give me the summary. Digital books are obviously what most people use now at this point. I think that there could be like AI read it to me, but the primary way that we translate knowledge to others is still by writing it down or recording it. So I don't see that going away, but it might not be my face saying it to you. It might be my avatar, because then I don't have to be there to do it, right? My avatar can do that for me, and AI can make it look as real as possible.
And then for this particular set of tools that you're building out, it's just within your university at the moment. Do you intend to build that into a company that you sell to other educators? What's your sense of where this is going to end up? Or will every physical therapy professor in America be building their own version? That sounds like a bit of a duplication of effort, but
in healthcare we duplicate a lot, but we are very against it. So obviously there's some IP issues, right? Like, I can't take what I did and sell it to somebody else, because that's owned by my university. But
you come to a deal with your university about that. Many universities have got similar arrangements.
I think I need you on my legal team.
I can point you at plenty of licensing offices all over the place, and how much they get and how much you get and what happens. But I mean, do you think
we'll talk later?
I guess the question is, I mean, I don't know where you are in the planning of this, but I just immediately go to there'll be a company, organization, there'll be the equivalent of a textbook, right? Somebody published that textbook behind you and around. Somebody paid money for it, and there's a business behind that part of the world, and they will be behind this too, right?
Yeah, we have an education-focused branch of our professional association, and they have a repository of teaching materials that we can use, and a lot of them are simulation-based, and I have a feeling that we may be opening up kind of an AI repository as well, and that would reduce a lot of the duplication, because anyone who is a PT educator can just go and get that and then use it, and that's what it's for. We then get a scholarly product out of it, so that makes a lot of sense, because that's required for us to teach. So
right. And not directly related to this, but since I have you and you are deep in this world, what's your sense about the change in PT that has happened and is happening with all of these virtual PT and now increasingly AI run virtual PT companies. Obviously, you have Hinge as public and
Yeah.
Sword and
Sword.
other
Yep.
guys, and a bunch of other competitors in different countries. What's your sense of how that's changing the experience for the PTs sort of out in the field and how they're doing? And what about is this a good thing for patients? Is this improving care? Give me a sense about where you think, the new form of virtual PT is.
Yeah. So, like most things, I think it has its really great advantages and its really terrible disadvantages. From a legal scope of practice perspective, that is not a PT. The PT behind it is the PT, right? And if I'm not getting services from a PT, it better not be billed as physical therapy, because that's fraud and that's illegal, and you will lose your license and all of those things. So I'm also very much an advocacy PT. I'm going to protect my license and my practice. On the other side of that coin, though, is access, right? Like, now we can get PT to someone who lives 200 miles from the closest hospital or PT clinic. I can take someone through their joint replacement rehab virtually, whereas otherwise they wouldn't have had any. So I think that it has amazing ability to get people what they need where they're at, as long as it's used properly.
Yeah, and I think that the folks who run those companies, and I've interviewed them all, would tell you that there is, I've said it, that there is a physical therapist license, behind the scenes.
Yep.
A lot of the things that they are replacing is that every physical therapist knows that they see somebody in a clinic or in the hospital, they don't get discharged. They traditionally got a piece of paper that said do these 15 exercises that they never did.
No.
Right. And if you can track them and also, use the technology now to figure out if they're leaning to the right, leaning to the left, and this kind of stuff, and actually, and then you can sort of have the AI both monitor them, ping them, and also, get a human in the loop later. I actually, I think there's a lot of promise there to expand it, because PT is one of those things where it's tremendously good if people do it. People don't do it. We all know that it's the same as exercise, right? It's very good if we do it, and whatever you can do to sort of push people down that path. And I think the integration, I've never run into a PT who said this is a terrible idea, that you should only do it under the guise of a human in a PT center, because they know they don't do it, and you can measure stuff using these tools that actually is very hard to measure in real life, right? The balance and angles and flexion and whatever that you can do now off the phone
on the screen. Definitely.
So I think there's a lot to be said for that. And what I think is yet to happen, is my commentary, is that those companies, there isn't yet kind of, and this is welcome to America, there isn't yet this sort of integration between, you have somebody who maybe has a primary care doctor, maybe doesn't, hurt their back, hurt their knee, hurt their shoulder, whatever, somehow ends up either with a surgeon or not with a surgeon, goes through. There's no real clear path right now for someone to get to a place. Tends to be a lot of PT happens around surgery and after surgery. And, frequently you could probably use PT to avoid surgery in some ways. So I think that entire sort of flow of the patient from, so something going wrong, I need to do something preventative / what can I do to, I felt my back, what can I do about it? We don't have that sort of concierge wraparound service. There are some people trying to do it, but that's the bit that I think where we need to integrate all of these different things: the technology, the PT experience. Yes, there may be people who do need surgery, there are people who don't. That whole thing needs to be fixed. But honestly, you can say that about any aspect of American healthcare, right? We don't do good primary care. We don't do good follow-up after surgery. We don't do good care coordination between sites. So
no, we don't. No, we don't. And what you're describing is really the role of the patient navigator, right? And PTs serve that role all the time in various systems and even in insurance companies.
And usually not being paid for it.
Or not well enough anyway to know the system like that. But just as a professional plug, direct access to physical therapy is available in all 50 states to some level or another. So if your back hurts, you can go directly to a physical therapist. We will help you figure out where to go from there. We will be your patient navigator, and we are happy to do it.
All right, brilliant. Well, I've been speaking to Dr. Kaelee Brockway. She is the professor at University of St. Augustine Health Services of Physical Reach, and she showed us a really interesting simulation tool that she's built for AI. We'll see how this goes, but I suspect that you'll find that your tools will be used by a lot more people than just in your university pretty soon, is my guess. But congrats on what you've done, and looking forward to seeing how it develops.
Thank you. Thank you so much.